I would especially like to thank our faculty, Dr. Loris Pegoli and Dr. Johnny Anderson. Dr. Loris Pegoli works as an orthopedic surgeon for hand and wrist at J Medical Hospital in Turin and at Humanitas San Pio in Milan. He absolved fellowships at Harvard University Hand Service, Massachusetts General Hospital, Boston, USA, and at Hirosaki University in Japan. He's co-founder and past president of RITH, World Research Institute of Sport Traumatology of the Hand, and founder and secretary general of the International Society for Sports Traumatology of the Hand. He's the actual president of the Sport Commission of the International Federation of Societies for Surgery of the Hand, EFSSH. Dr. Loris Pegoli is a member of the Italian Society for Surgery of the Hand and a member of other international societies, among which are the European Wrist Arthroscopy Society, the International Society for Sports Traumatology of the Hand, and the Japanese Society for Surgery of the Hand. He is faculty member of the European Wrist Arthroscopy Society and held courses in many foreign institutions. He collaborates with foreign universities such as the University of Hong Kong and the Keio University in Tokyo. Dr. Johnny Anderson works presently in Doha, Qatar. He is an orthopedic surgeon and hand surgeon specialized in wrist arthroscopy, ligament reconstruction of the wrist and thumb among athletes, joint replacement in wrist, thumb and fingers, and nerve decompression of the hand and forearm. He performs all general hand surgery procedures from the fingertip to the elbow. He was educated at the University of Gothenburg and has worked as an orthopedic and hand surgeon since over 20 years. Dr. Anderson wrote his PhD thesis on wrist arthroscopy and wrist instability in 2016 at the Sahlgrenska Academy in Gothenburg, Sweden, and has published over 20 scientific articles. He has a large network of international well-known wrist surgeons and has ongoing research projects. He's a member of the Swedish and European Federation of Hand Surgery and several international wrist arthroscopy faculties. Among others, he has worked with Professor Marcus Elias in Barcelona and Professor Jörg Bahn in Aachen, Germany. Dr. Anderson has acted as the head dean of education in hand surgery for 4 years at Sahlgrenska University Hospital in Gothenburg, Sweden. We see here now our agenda, and we will start our program with a presentation about the endoscopic carpal tunnel release, followed by basic and advanced techniques for wrist arthroscopy and the TFCC techniques. Thank you for your attention. We will start now with the presentation of Dr. Pegoli.
So I would like to thank you, everybody, but I guess there are people from many different countries, so I really would like to send a hug to everybody, because a virtual hug, considering the period that all of us is pretty much having a hard time all over the world. So let's hope soon we'll be able to hug for real. So my goal is to describe the one portal endoscopic carpal tunnel release. The endoscopic carpal tunnel release is not a very new and a technique that was created in the last times, because since many years ago, already colleagues have described this procedure with lots of cases. So my goal is to describe the AG1 portal procedure that is performed with this device. That is the Artrex center line. This is the way it is called. A device or a procedure to be effective has to be easy, must have an easy learning curve, and it must give very good results. And this is exactly what is this procedure. You can see now the instrumentation that is needed. It's a very simple instrumentation. We just need an optics, a scope that is a 2.9 scope with a 30 degrees of the lens. We have a blade, a disposable blade that will be uploaded on the scope, as we will see afterwards, and some other little tools that will help us in creating the tunnel where we are going to work and make the procedure. Considering the technique, we will see some pictures, and then we'll see also a video. Imagine we will be able to see in a real cadaver lab. The procedure is performed under a local anesthesia, carbocaine and carbonate. Very few drops are used. I put about 2 to 3 cc of anesthesia in a place between the FCR and the palmaris, as you can see in the upper right slide, and 1 drop of anesthesia at the level of the volar crease of the wrist, the place that will be the incision site. The procedure is performed under ischemia, and we put a tourniquet at the level of the arm. This is just an animation by Artrex that starts giving you the idea of what I will show you afterwards. These are the different passages that we will see in details shortly. You are seeing the preparation of the passage and how actually the blades work is a retrograde blade and the opening of the transverse ligament. And we will see little by little the different steps. Considering the landmarks for the incision, it says to point the pisiform bone, to proceed proximally of about 1 centimeter and another centimeter medially. The 3rd centimeter is the one of the incision site. 1 centimeter is the one described, but with experience you will be able to do even a shorter incision. At this point, the assistant holds with 2 skin hooks the incision site of the skin, and we are going to localize the antebrachial fascia through a blunt dissection with a mosquito. At this point, we are going to grab with the pickup the antebrachial fascia. The direction of the pickup is done on purpose transverse through the fibers of the antebrachial fascia, as not to make it slide away. Little by little with the mosquito, we create a hole in the antebrachial fascia as far as to identify the tunnel, the carpal tunnel. I do with blind dissection. Other people prefer to do a small incision with the blade and then proceeding deeper. Once we are inside of the tunnel with the blunt dissection, we open up a little bit the mosquito and we grab the edge of a transverse ligament. At this point, we use these little tools that help us in cleaning up the tunnel. This passage is extremely important because with a little bit of experience, you are able to feel, imagine that this instrument is your finger inside of the tunnel. You are able to feel if the fibers and the tunnel is more wet or is more dry. And this is extremely useful because it gives you the idea also about how much inflammation we can find, how much tenosynovitis inside. Afterwards, we clean up and we create a little bit of space inside of the tunnel. We use this other tool that is a dilator. There are 2 different sizes. At this step also, little by little, you will be able to skip also this passage and to make the procedure even faster. Once the tunnel is created, we insert from proximal to distally the blade that is uploaded on the scope, and we put it inside of the tunnel. You will see how. Once we are inside, we will be able to see upwards the transverse fibers of the ligament. We have to go till the very end of the ligament, pull up the blade, and coming back from distal to proximal as to be able to to achieve the complete opening of the tunnel. And this is the nerve that it goes inside the space that we have created. It is extremely important to have a U-shape opening. What I mean, if you see on the right little picture, you will see there is a V-shape opening. We must be, this is this indicates that the transverse fibers have not been opened completely. This is not a failure of the procedure, but it gives also the chance to make the compression of the nerve even stronger, because we have just one place of impingement of the nerve, so more pressure on it. These are some tips. When you do the first procedure and you introduce the blade, do not put the arm elevated like I do. Neither I did on purpose. This is because at the end of the proximal end of the transverse ligament, it's quite stiff. So you risk with the sudden movement to cut also the skin. So at the beginning, it's much easier to learn to put the arm attached to your chest and move all your chest together. So with the chest, you push the arm. In this way, it's definitely more difficult to have a sudden cut of the last part of the ligament and to create a skin cut. After the procedure is done, we put some Steri-Strip and a dressing, and the patient is allowed to move right away after surgery. This patient usually take off the dressing after 5-6 days about, and they are allowed to drive the following day, of course, without doing 800 kilometers, but they're allowed to do their daily life activities. And this is right after surgery and after the release of the tourniquet. Considering the post-operative protocol, I always suggest the patient to do 1 session of hand therapy after the removal of the dressing. This is to teach them how to treat the scar, both the one of the incision at the level of the palmar crease, and also the area between the thenar and the hypothenar muscle. Despite the fact this is an endoscopic procedure, is not something magic, so the pillar pain for a while is felt by the patient still for a while. So it's worth to teach them by themselves during the day, few times a day, to massage both scar. And this is the time that is needed. You will see the video of the procedure to show the real time that it takes. It takes about from 1 minute, 1.5 minutes at the end to make the whole procedure. In this case, I'm not even using the skin hook, for instance. See, with the blinded section, we grab the antebrachial fascia. Then with blind dissection, we go with the mosquito. We are underneath, inside the carpal tunnel. Your assistant holds the antebrachial fascia. You can use 1 or 2 skin hook. This is extremely important because it gives you the direction of the carpal tunnel. It gives you the length of the transverse ligament. Sometimes it's shorter, sometimes it's longer. And then we get inside with the blade. Some tips are to keep, as you can see with my left hand, to keep the fingers bended, flexed. In this way, we have a release, the tension of the flexor tendons, and this gives you more space inside the carpal tunnel. You see the light appearing, and the light test is also another way to have a further check of the complete opening. So probably was 1.5 minutes, couple of minutes. With a skin hook, we close the skin and we let, as we said before, the immediate mobilization. Sometimes I also put some glue, that's it, without any dressing, but patient sometimes come back asking for a dressing as they realize that they had surgery. Otherwise, it's going to be a little bit more painful for a while. So as I mentioned before, to check the complete opening of the carpal tunnel, you can see on the left side the intact ligament in the middle, the V shape, something we don't have to achieve that will even make worse the situation, while on the right picture, the complete opening. Always start from the very end of the ligament. Otherwise, if you start from the middle part of the ligament, sometimes too much muscle, too much fat will get inside, and you might have difficulties in reaching the very end, the very distal part of it. As I mentioned before, the light test can be useful. And another very useful test is the palpatory test. We use the dilator that you see on the right side. We put inside till the end of the tunnel, and pushing towards the palm, we come back. If some fibers have left, we can feel a trick. It means that there's something more left. So we have to go back and open it completely. The most important thing is to see properly whatever we do. I said that it takes about 1 minute, 1 minute and a half, couple of minutes. At the beginning, about 20 years ago, I was taught to make to make carpal tunnel release directly with endoscopy more than open. And it seems very easy procedure to be performed by the one who taught me. At the beginning, it takes 10 minutes, 15 minutes. So it's just question of learning curve, gives you a lot of satisfaction. But first of all, don't make a mistake. And always tell the patient, especially at the beginning, there might be the chance for a conversion to open procedure. Of course, in case of bad vision, distalized muscle, latent tetany, we have to choose for open procedure. In case of functional limitation, maybe with a bit of experience, we will be able to do endoscopic carpal tunnel release also in the case shown. Severe hypertrophy, in case we need some specimen, and in case of recurrences. Concerning wrist fractures, I always been told that is a contraindication for endoscopic carpal tunnel release. But it depends really about what kind of fracture, what kind of wrist we have in front of us. In 9 cases up to 10, we're still able to do endoscopic release even after a distal radius fracture. Concerning complications, in the endoscopic carpal tunnel release, they are actually smaller than the open procedure, or especially in those mini open incisions. Sometimes, apart colleagues with a great experience, some surgeon pretending to do a small incision, they just make a little cut and they go blindly with the scissor inside. So this is not a minimal invasive procedure because we have a small cut, but this is a very invasive procedure. So always it's better to do the classical little cut between the tenar muscle than to go blindly with a scissor inside. This shows how the conversion rate was in the last, it was for 15 years, but it's even higher. Smaller the incidence of conversion, as you can see here on the cases. Thank you for now. This was the first one. Okay.
Thank you very much. I will bring up Paul, and whoever likes can join answering this question, and maybe we can also discuss it. Here is the question coming in the chat room.
Okay, let's see.
This is now for the participants to answer if they believe that if a distal radius fracture represents an absolute contraindication for endoscopic carpal tunnel release. Yes?
So from what I see now, no one has replied yet, but I just told of the presentation. So Any questions?
Yes, this is Johnny Anderson. Can you hear me? I have a question. Yeah. What about motor nerve injuries? Have you ever experienced that? Because sometimes you can have a recurrent nerve or a transverse nerve coming up through the ligament. Are you always sure that you can see that?
Yes.
Sorry.
Yes. Well, with the endoscopic procedure, we can see the motor branch very well. That is the main difference between doing the mini incision and go blindly with the scissor or be inside the tunnel. You are able to see the motor nerve. With the blade inside, you go further. You can cut the first part of the tunnel distally. You can put the blade down, come approximately. You can put the blade up again, move a little bit forwards the motor branch, and you keep on cutting. As far as now, luckily, we didn't have any motor branch cut. If it's there, you can see very well with the endoscopic procedure.
That's fine. Have you talked about pillar and pain?
Yeah.
Do you experience a shorter time of pillar pain compared to open release? And do you have any difference in terms of complex regional pain syndrome? Have you any experience about that?
At about 5 months, the results between endoscopic and open release is actually the same. So we are not say something magic. The immediate post-operative mobilization and the absence of the incision between the thenar muscle and the upper thenar muscle allows the patients, in our experience, a faster recovery. We do have scars. We have 2 scars at 2 different layers, because if you have the cut on the skin and cut of the ligament transverse, we do have 2 scars, one over the other. The endoscopic procedure at the level of the carpal tunnel as well has like a trigger finger or other anatomical district. The main advantage is that we have 2 scars at 2 different levels, so they bother themselves less. So at the beginning, patients have less pain, but at about 5 to 6 months, the results of the pillar pain is pretty much the same.
Okay, thank you.
Working?
Working.
Okay, so I will give you some description of how we can actually walk inside the wrist and how useful is the arthroscopy, that actually is the only procedure able to give with 100% score the diagnosis of something that is inside the wrist. Nowadays, we can reach actually every single part of the wrist. Arthroscopy has a double goal on the wrist. Has the chance to make diagnosis for ligaments, cartilage, and though give an indication for the proper eventual secondary surgery. Let's remember that has been described in many papers that an MRI is able, even if performed in the best way possible, to give about 50% of the certainty of a lesion of ligaments, especially a microphone, especially if we are at the early stages. Ligaments in the wrist, they are not broken or not broken. Their lesion evolves in different steps, mainly 4 grades of lesion. And especially at the very first step of this lesion, grade 1 and grade 2, let's think about the Scapholunate ligament, we see the condition only in dynamic action of the wrist. The MRI is a static instrumental evaluation. So we'll never be able to realize if there is a lesion in the first steps. And this is mandatory to give the proper treatment. If arthroscopy has to be the option instrument for surgery, we can use it to treat early and now also describe the advanced stages of scapholunate ligament tears. We are able to use arthroscopy to repair TFCC tears or debrided, to remove ganglion cysts, to proceed with synovectomy, arthrolysis. Also help us for performing intercarpal fusion, performing arthroscopic grafting, and some other procedures such as radial styloidectomy or wafer resection. So first of all, we have to get inside of the joint. We need some traction towers from older models to more sophisticated one, like the one shown in the picture. And then another way to create space inside of the joint is for one who likes to put water inside. I'm saying so because in the last 10 years, probably I've been using the so-called dry arthroscopy, and most of my colleagues doing wrist arthroscopy are on the same way that I do. We have an excellent view of the wrist even without water inside. Not having water inside of the wrist helps us also in having more clear tissue if we have to go further with an open surgery after arthroscopy gave us the proper indication. We need, of course, some particular tools. Camera. Nowadays we have 4K and even more sophisticated camera. An image recorder that I would suggest, if possible, to have every single operation, because apart from scientific purpose, also has a medical legal utility. A light source, an engine that can be used for different kind of blades, and we will see shaver and bars. And for those who are used to use water, a water pump. The instrumentation uses the scope. There are mainly 3 dimensions of scopes that are used in the wrist, from 1.9 to 2.7. Also 2.9 can be used. I personally use all the time 1.9 because it's the same tools that allows me also in other procedure to go to the CMC joint, MP joint, and even more distally with inclination of 30 degrees that you'll see there. Arthrex has developed also another tool that is called a nanoscope, that is 2.7, extremely light, that it's kind of a wrist arthroscope, a wrist scope that I think will be useful also for a knee surgeon and shoulder surgeon. These are a description of the different scope available. You can see there are more than HD high definition tools that we do really have an excellent view nowadays. One of probably the simplest tool, but one of the most important, is the probe. That is this little tool with a blunt tip, and this is really represents our finger inside of the joint, because when we hold it, we can feel tissue, we can grab structures like ligaments, like the TFCC, the fibrocartilage complex. We can see how it holds. The probe is able to go inside the space between the carpal bone, though giving the proper grade of the lesion. If only the tips goes inside to bones, is a first degree lesion. If we are able to go inside and turn, or if we pass with the scope from, for instance, the mid-carpal joint to the radiocarpal joint, it means that the ligament is completely broken. And so we are in presence of a 4-degree lesion. Another extremely important instrumentation is the shaver. We do have different kind of blades, as you can see here. We can use it for synovectomy. so we can clean up the pain of the patient, even in case of absence of lesion. In case of a tear of TFCC before a repair, can be arthroscopic or open, it allows us to clean up the two edges that has to be sutured one to another. As like we have to glue two pieces of wood, we have to clean up the surface properly to make it hold. And then many kind of bars that and grass that allows to do some kind of procedure, such as in the case shown there, radial styloidectomy. This case was an impingement between the scaphoid and the radius, or allows us to proceed with a wafer resection, that is a shortening, arthroscopic shortening of the ulnar head. They allows us also to create tunnels inside of the carpal bone in case we need to put some grafting, some bone grafting, like in carpal cyst or the arthroscopic treatment of the early stage of Kimbach disease, or also in case of non-union, as described, to create the space for bone grafting, like in scaphoid non-union. You can see the variety of the bars that are available. A lot of instrumentation help us also, like different kind of grasper. In the lower part, the new one for the nano grasper, actually. And another instrument that is useful is the radiofrequency. Radiofrequency can be used for retentioning in case of some early stages of the scapholunate ligament tear. The goal of the radiofrequency is to create a heat source close to the anatomical structure and to make it retract and retention it. Despite the fact that will last for longer or less, can be a part of the procedure itself. The radiofrequency can be used also in case we need to proceed, for instance, like a wafer procedure. At the beginning, we use the ablation to take off the cartilage, the remaining cartilage of the ulnar head of the radial styloid. It allows also to perform some steps of arthroscopic arthrolysis. Especially in case of arthrolysis, it's quite a bleeding procedure. So the radiofrequency allows us also to contrast the bleeding after the cutting of the lysis inside of the wrist. We are able to reach, as I mentioned, pretty much all the different aspects of the wrist. The portals are named according to the extensor tendon compartment, as you can see in the picture. So they are named like 1-2 portal, 3-4, 4-5, considering for the extensor communis. Then at the level of the radiocarpal joint, then we have the MCU and the MCR, so mid-carpal ulnar and mid-carpal radial, the SDT joint portal, and the distal radio-ulnar ulnar joint portal. This is the radio-ulnar joint portal. We do have two portals, one proximal and one distal, actually, to the TFCC. The proximal one is allows us to see the foveal attachment of the TFCC and to check the cartilage of the ulnar and between the ulnar and the radius. You will see here the different steps, the different layer getting deeper according to the different anatomical structure. The video shows the proximal portal. Actually, we are under the TFCC and we follow it until its attachment, and you will see the bump and the synovitis where the tear was. On the bottom right side, we can see the ulnar head and the cartilage. This joint is extremely tight, so we have to be extremely careful in not to create any damage to the cartilage. Then we have what we can call the more classical radiocarpal joint portals. And as I mentioned, they are in relation of the extensor tendon compartment. Here is better seen. Through this portal, we can perform many procedures like the evaluation of the SCC, ligaments and cartilage, removal of the ganglion, both dorsal or volar, radial styloidectomy, buffer resection, debridement or repair of the SCC, and the arthrolysis. This is the view. On the, in the lower part, we have the radius. The one visualized now at the bottom are the volar ligaments. We are on the radial part between the scaphoid and the radius. We are coming back to the middle part, the volar ligament. This is the passage between the scaphoid and the lunate, you can see. And this is the scapholunate ligament, the part that with the probe we need to test in case of suspicion. This is the radiocarpal joint from the ulnar aspect. Here there is a lesion of the SCC. With the probe, I'm checking the foveal attachment and the peripheric attachment. You can see the synovitis of the lesion, and the hook help us in understanding how much it holds. We are proceeding more centrally, medially to the joint. We can see this, the condition of the cartilage. This is the passage. This is the scapholunate ligament between the scaphoid and the lunate. And with the probe, we can see if we are able to get inside with the tip, if it holds, or we can proceed further. These are again the anterior ligament from the other side, and we are moving to see the scaphoid. With the probe, we can also give a little push on the cartilage. If the cartilage comes back easily, it means that it still helps. What is extremely important is to evaluate the FCC. At the beginning was described only the trampoline test, thanks which we were bumping with the probe on the FCC, and we have a rebound. It means that the FCC was fine. But this gave a false negative. In fact, since about 15 years ago, thanks to Dr. Nakamura, it was shown that one of the most important attachment of the FCC is at the level of the foveal part. So in this way, we are not able to check if it works or not. This is why it was described the hook test, thanks which we grab literally the TFCC and we pull it up. And if there is a lesion, this is what happens. As you can see here, I'm pulling with the probe and we can see that it's not holding from underneath, even if the trampoline test was fine and there was a continuity of TFCC seen from the radiocarpal joint. Then we do have the midcarpal joint, as I mentioned, the midcarpal ulnar and the midcarpal radial and the STT joint. And here the relationship with the tendons. We are able to evaluate the ligament. Remember that the scapholunate ligament, for instance, is done by 3 different parts. One can be checked from the radiocarpal joint, and the other one has to be checked by the midcarpal joint. Otherwise, we risk to miss a partial lesion. Of course, it's extremely important to evaluate the cartilage, especially at the beginning in the first stages, like a second stage. Some examination not able to check the integrity of the cartilage. It is extremely important in those cases in which we have to perform like a salvage procedure. If we have to choose between the radioscapholunate fusion and leaving the midcarpal free, or for instance taking away the scaphoid and fusing the lunate with the capitate. The indication is given by the cartilage condition. We can also treat STT arthritis, performing the distal scaphoid pole resection by arthroscopy. Ganglion removal, not all the ganglion derives from the radiocarpal joint. Many are from the midcarpal joint or from the STT. We can perform carpal fusion and bone grafting, as I mentioned. These are the structures that we are able to see from the midcarpal joint, and these are the ligaments that we can see, like scapholunate ligament and lunotriquetral ligament. This is the view that we have when we get inside the mid-carpal joint, just get as a reference the capitate, the big bone that is there. And then little by little, you get used to switching the portals often to explore all the mid-carpal joint. I tend to make the first portal at the level of the MCU because it's a little bit larger. And then after I use the MCU to create the MCR, I switch the scope in the MCR and I keep on checking everything. These are the structures and the stability. We are checking the stability of the ligament. I'll show you here. We are preparing from the MCU, the MCR portal. Always the capitate at the top of the slides of the video. And underneath we locate the lunate, and then we check from one side the lunotriquetral ligament, trying to get inside with the scope, with the probe, to see if it holds or not. And then on the other side to check the passage between the lunate and the scaphoid. Remember that it's easy to find a little step between the scaphoid and the lunate. It can be useful sometimes to push the tubercle or the bone from outside to see how the degree of instability looking inside with the scope. We can see if there is a synovitis, and we can proceed with the shaver to clean it up. This is where the scope is put in the MCR again. The capitate, the big bone, the lunate. I just wanted to show you how the probe, see, we can feel it outside, just putting the probe in, the stability of all the bones. This is able to go inside and to rotate. So it's you see the stability, the capitate upwards, and the lunate, and the passage between the bones. This is another view. This is the lunate again. See how stable with all the synovitis. In case of absence of lesion, we can proceed with the shave and clean it up. And this is the step I was telling you before between the lunate and the scaphoid that is quite often present, but it's not an indication of the lesion. This is the STT. This is the distal pole of the scaphoid, as you can see. And after cleaning this joint is extremely tight. So at the beginning, it takes a while with the shaver to clean it up from synovial, from cartilage, little body that go inside the joint. And little by little, we create the space to eventually proceed with other procedures, such as distal pole resection. I will just show you in this video the passage between the trapezoid and the trapezium and the cartilage between the two. These two bones, especially in arthritis condition, are pretty much fused one to another. So you can see here pretty well after cleaning the synovia, the passage between the trapezium, the trapezoid upwards. Here again, see. On the left, the trapezium, and on the right, the trapezoid. We don't have to forget that we have the chance to use also volar portals that are extremely useful for the assistance in distal radius fracture, especially to check the dorsal ridge of the radius, to check ligament from the other side, for removal of the cyst, as well as to proceed with the arthrolysis, the dorsal part of the complete arthrolysis. When we do a full arthrolysis, we have to do volarly and dorsally. So we have to cut the adhesion both dorsally and volarly. Let's not forget about the complication. Tendon lesion, nerve lesion can be caused mainly by the surgeon, as well vascular and cartilage. This is just an example of aneurysm of the radial artery after ganglion removal that fortunately didn't cause any particular problem to the patient. but you always have to be careful, to be gentle